This is a study of Inebilizumab, which is a CD19 depleting antibody. And in NMO, we've been using a CD20 B-cell depleting antibody, Rituximab, for many years. We're all used to it. Patients are very fond of the medication. Seemed to work very well. It had never been formally trialed in a population with NMO until a recent one, a small one in Japan, but we all had a lot of experience with it. And so that might have provided some reassurance and comfort to the industry partner who initially did the trial in NMO. They conducted a worldwide phase 3 blinded placebo-controlled study, and it proved to be remarkably effective, reducing risk of relapse by 77%. That's the backstory. The smaller part of that story is that since it's been approved, people have been asking themselves, well, we have rituximab that we use off-label, and it's cheap now, especially the biosimilars. And we have inebilizumab, which has the scientific evidence to support its use in NMO, but it's expensive. Aren't they really the same? That's kind of what's been bugging people since the approval of inebilizumab. And what the inebilizumab folks have done is they said, well, it's really not the same. If you look at the patient population in the trial, those who were on rituximab, who were then enrolled in the study, they had relapses. They failed that drug. And then when they started inebilizumab, they did not. And here's the proof. And so we kind of looked at the data, rubbed our chins. We're like, wow, that could be real. Does that happen in the real world? So this case series was really an attempt to try to reproduce what we saw in the clinical trial in the real world. And several investigators came together and said, all right, let's take all of our rituximab patients who were transitioned over time into inebilizumab, and let's just see, are there cases where patients who were on rituximab relapsed on rituximab, but then did not, or what happened after they switched to inebilizumab? That was really the question. So we didn't try to limit or bias the population. We just took everybody who transitioned from rituximab to inebilizumab, not people who had a gap in their treatment, just those who were just transitioned. And they might have been transitioned for a number of reasons. Maybe the patient preference, maybe copay assistance, maybe availability. Whatever the reason was, we just wanted to evaluate all of those cases. So there were 14 cases total, 13 of which were aquaporin 4 positive, one off-label aquaporin 4 negative use, who still met the criteria, but it was off-label. And what surprised us is that there were quite a few relapses in the rituximab group, pretty similar to the numbers in the trials. I think out of the 14 patients, there were 6 who had a breakthrough relapse on rituximab. And it occurred even, during the period of time that we would expect rituximab to be in effect. Now, they still had some circulating CD19 positive B cells when they were tested. So maybe it was that the rituximab wasn't fully depleting the B cells, or maybe some of these B cells were internalizing their CD20 and they were still expressing CD19. So there's lots of follow-up studies that can be done on this to try to explain why this is true. But then when they were transitioned to inebilizumab, in that 1.5 year period that they've been followed since the transition, there have been no relapses. So this really is similar to what we saw in the trial. There are people who will fail rituximab who will respond well to inebilizumab.